leukemia last class, and we said one of its problems is that it proliferates so much that it takes up the space that the platelet would take. Well, so people, therefore, with leukemia is going to have these problems. But obviously, it's not just people with leukemia, but there are other types of anemias, right? Or people who just naturally just have anemia. And that was kind of Estrie's question, right? Like, what is the most common? And we're going to talk about a few other kinds of anemias, right? Or a few kinds of anemias that a person can have. Okay, right before, I want to show you this little video here. Let's see if it goes there. Maybe not, but let's play it. Oh, let's make it big, shall we? Is it loud? Is it loud? I don't hear it. Oh dear.
Hit it with a hammer.
Is it me? Is there a volume in any of these things? How about this one?
It's like a beginning of like a zombie movie.
I didn't know how to raise the volume. Anyone knows how to raise volume? I'm gonna turn every knob. Nope, it's not working. Sorry, I don't know how to turn the volume up. Okay, I'll just tell you what it's saying. Okay, so on your own time, you can definitely watch that. I'll have to ask about the volume. So what it's saying is explaining red blood cells and how they work, right? So red blood cells are concave cells that they don't have a nucleus on the inside. That's why they have that like little indentation there, and they carry oxygen, they have iron, they have hemoglobin, right? And you'll learn more about this in patho, right? So the way this red blood cells work is without the red blood cells, you will not have oxygen. And so now the oxygen, right, has to connect to the hemoglobin, and that's how it gets its oxygen. So if there's a problem with hemoglobin, then we're not going to have oxygen. And when the blood does break down, we have the hemoglobin that also detaches and the iron that detaches, and the body has to break down the hemoglobin, which makes the yellowness that happens when a person has jaundice. So all of these things it was going over. You'll learn that in patho. But the idea that I want you to understand is that red blood cells carry oxygen, and if you don't have a lot of red blood cells, you won't have oxygen. And a little bit of another thought too is we already mentioned where red blood cells are created. They are created where again? In the bone marrow. Another aspect that I hadn't mentioned is that because when the blood cell breaks down, eventually it will get to the kidney, right? Because it's going to filter, the kidney filters everything. So once the kidney is filtering things, it sees the iron, it sees the electrolytes, it sees all these things. It decides what it's going to send back and what it's going to reuse and what it's going to excrete, right? So like your yellow urine comes because of the bilirubin, right? So it excretes those things, which means since the kidneys are going to kind of somehow connect to blood in the sense of it's filtering some of its products, it plays a role in deciding or helping the body realize when it needs to produce more blood, because some of its byproducts of the breakdown, it's getting it, right? So it's like, oh, I got like 30% of your breakdown today. I think you might need to make some more, right? And that's where we come in when we think about dialysis patients, where they have to get something called epigen, which is erythropoietin, which is what the body naturally produces in order to make blood, right? So I want you to keep that in mind, that when the body doesn't have enough blood, there is a way to create it. It's going to create it in the bone marrow, but the organ that tells it to be created or tells the body it needs to be created is the kidney, and it does that through signaling through the hormone of erythropoietin, right? Which tells me too that when a person doesn't have oxygen, which is on the blood, then the body is going to tell the kidney what? Make more blood, because it thinks, oh, you don't have oxygen because you don't have enough blood. So if you make more blood, you'll have more oxygen. Yes?
That was the Lance Armstrong drug, EPO.
Oh, yes, that's true. Isn't that why he got in trouble? Mm-hmm. That's right.
Because it wasn't a drug, he was taking his own hormones or something like that.
That's true. That's true. Thank you for sharing that. So that's another thought to remember when you're thinking about, how is blood created? When is it created? Why is it created? All of that kind of stuff. And this little video kind of talks a little bit about like the different elements, right? And also when we think about blood also has iron. And so in order for the red blood cell to work, it has to have the hemoglobin, right? It has to have the iron. So if something's wrong with hemoglobin, blood's not going to work properly. Something wrong with iron, blood's not going to work properly, right? So then we have to give the person iron, right? And hemoglobin is a protein. We have to make sure they eat well, all of those kind of things, right? Moving on. So you can watch that. Okay, so what is anemia? Anemia, right, is when red blood cells, all right, so right before in my notes, red blood cells are called erythrocytes. Remember I said you have to remember that. It gives the blood its characteristic color, right? So, and carry oxygen from the lungs to the tissue. So that's another connection we have to make, right? Where does the oxygen come from the blood? Obviously the lungs, because we breathe in oxygen and then it gets to the lungs, right? And when we get to cardiac, we'll learn how that works, right? How it flows from the superior, inferior, get to the right, to the left, to the lungs, then back around, right? So we need to remember those things, which is going to tell us also then that the heart is connected to red blood cells, yes, but it's also connected to the lungs too, right? So if something's wrong with the heart, we might also have problems with the lungs, right? When something happens to the heart, the person's heart beats fast, right? It beats fast, but also they breathe faster because they think, oh, I need to work my lungs too, because they're connected, okay? So we'll talk more about that. So hemoglobin is an iron-containing protein in the blood, and the red blood cells transport oxygen to the tissue. Okay. So when we think about what's the measurement for men and women, remember these measurements will be given to you, so you don't have to memorize them, but you have to know what they mean, right? If it's high, if it's low, what it means. So if we have anemia hemoglobin, we have hematocrit. When we think about hematocrit, we think about the blood itself, right? So it's like, okay, the way to think about it when they're doing the lab, so they'll do like the centrifuge and then like shake the blood, and then they can do the compartmentalization. How much is this? How much is this? And how much is that? So if they see hematocrit is low, that tells them there's something wrong with the blood, there's something wrong with the kidney, and then they start to dig deeper to find out what is the problem, okay? So anemia, so it's a decreased amount of red blood cells or hemoglobin in the body, right? And since you need those to carry oxygen, it will affect oxygen. If we can have iron deficiency, we can have the vitamin B12 anemia. These are the different kinds of anemias, and all of these somehow will eventually affect our blood, right? So this is the whole idea. So when we're checking labs, we're checking for hematocrit, we're checking for hemoglobin to allow us to identify where the problem is and where do we need to investigate further. Is it the iron that's the issue? Is it the hemoglobin that's the issue? Is it the oxygenation that's the issue? Is it the kidneys that's the issue? What is the issue? And once we do the labs, it'll signal us which place to go, right? So let's see, anemia can also be classified in several ways. So we have the physiological approach, which classifies anemia according to whether it's a deficiency in erythrocytes caused by a defect in their production or by their destruction. So when we talk a little bit further, we'll see which one is which, right? So we can either have whatever it is, iron, it didn't make me enough iron. You don't have enough hemoglobin. That is not having enough. Or it can be, well, something is happening and you have lysis. It's being destroyed. And so even though the end result are usually going to be the same thing, but how we intervene will be different, right? If it's something that's in malproduction, I might need to give them something, right? And if it's destruction, I might need to find out why it's destroying to stop it, right? So the interventions may be different depending on what the problem is, or it may not be as well, right? If you don't have enough iron, I can still give it to you, right? And if you're being destroyed, or when we think about giving blood. Whether it's iron deficiency or lysis of some kind, you might still have to give blood. So the results or the interventions may be the same, even though the causes are different, right? Okay, so this is what I was referring to as in the kidney playing a role, right? So we have erythropoietin. It is produced by the kidney, and it is produced when the body recognizes that there is a reduction in blood or when there's a reduction in oxygen in the blood, okay? When we see COPD, we'll realize that, hey, that's it. It's taking effect, right? We have the pink puffer in COPD. They are turning pink because the body is producing more blood, right? Because they don't have enough oxygen, and the body thinks, hey, I know what to do. If I create more blood, you'll have more oxygen. So we'll see that then, right? But it's a kidney that's playing the role. So when we think about how the kidney connects to anemia, we think about hypoxia, right? So what is hypoxia? Hypoxia, induced factor in a type of transcription factor, right, that responds to the changing level of oxygen level in the cell. So once the body starts to notice oxygen level is decreasing, then it reacts. And one of its reaction is by sending a signal to the kidney, right? So when there's an inadequate production of erythrocytes, that may result in marrow damage. Because of whether it's bone marrow damage, then we might have erythropoietin is triggered, right? If there's a hemolytic anemia and cells are being destroyed, erythrocytes are being destroyed, that may cause the erythropoietin to be also released then. So anything that's causing, in the end result, decreased oxygen, whether it's because things are not being produced enough or blood cells are being destroyed and the end product is no oxygen, erythropoietin will be produced, right? And we mentioned the dialysis. It's not the person's body per se, right? It's because the blood is being filtered and then it's being destroyed, and by the time it comes back, it's less. And the body senses that, right? And when we talk about the heart, we'll notice how it can realize when there's less blood. The heart has receptors that when it expands, it says, hey, we have enough blood. But when it doesn't expand enough, it says, oh, we don't have enough blood. And it tells that to the kidney, and the kidney is like, oh, you need to make more blood. So there are things in the body that tells it whether there's enough blood or not, which is going to then make it decide, I'm going to create more blood. And we'll talk about them as we go along. But the notion is, anytime it feels like there's going to be a problem with oxygen, it's going to send signals to the kidney, which is going to trigger the erythropoietin, which is going to create more blood, okay? So now let's talk about the causes of anemia. Why is there anemia in the body? Again, we mentioned there are two kinds that can be, right? Not enough production or destruction. And so we'll get and breaking down the two different parts. So we have, again, remembering reticulocytes, same thing as red blood cells. Anemia is a loss of red blood cells, right? So it could be because of menstruation, a very natural thing, okay? Or it could be GI bleed because of an ulcer. It could be because of hemorrhoids, right? So those are some of the reasons. It could also be because of poor nutrition, because you need iron, right? You need the protein, the hemoglobin. Protein comes from food in order to make the blood. So if you don't eat well, you're gonna have poor blood, right? So poor nutrition can also come because of pregnancy, right? So one of the reasons, and when you get to OB, you'll see this as well, right? When a mother throws up all the time, right? With hyperemesis, she's not keeping the food, and so she can't create the things she needs, the cells she needs. That includes blood. And so eventually, because of her poor nutrition, unable to eat because of nausea, or throwing up after she eats because she can't keep the food down, that's malnutrition. Then she's going to have problems creating blood, so poor nutrition. So also the diet too. Different places, depending on, do they have enough folate? Do they have enough iron? If you don't get enough iron in your food, you're going to have problems with anemia. And then we have the B12, right? That's another type. So we have B12 is found in the intrinsic factor in our stomach. And if something is wrong there, maybe because of a surgery, they had to cut and reduce, right? When people want to lose weight, sometimes they do that, Billy Roth or something. Anyway, it reduces the size of the stomach, and the stomach lining has intrinsic factor. Intrinsic factor is what helps digest B12. And so if you don't have that, you're gonna have pernicious anemia, right? So that's another reason. Or it could be because of absorption. You ate okay, you ate enough of the right thing, but something's wrong with your intestines. Like if a person have colitis or irritable bowel syndrome, the intestines, right, the small intestines is where the food is supposed to be absorbed, right? It gets broken down or churned, whatever, in the stomach. It goes to the small intestine and it absorbs everything. But if something is wrong with their small intestine and we have to either cut it out or it's not working properly, you're not going to absorb the iron, the B12 or whatever it is that you need to in order to create blood properly, right? Then you also have, it could be hereditary, right? I mentioned before, there's one that Mediterranean people have. Do you remember which one I said it was? That one was thalassemia, right? So that could be a problem as well. Another hereditary one, I mentioned the name. Do you know the other one that's hereditary? Sickle cell anemia. That one's a hereditary one as well. And so the cells are not producing properly. They becoming S-shaped. They're going to get clumped together, stuck in a place, and not allow oxygen to go to the next area. So these are some problems there. Okay, so this is kind of a repetition. Let's talk about how do you notice a person who has anemia? What would you see? Someone from this group right here, tell me one thing that you'll see that you're like, oh, this person has anemia, just by looking at them. Yes, they're fatigued. They don't have any energy. So someone here, give me another one. And you look at them and you see like, oh yeah, they have, it doesn't matter which one. You could just tell me one thing that you're like, you'll figure it out later what it is, but go ahead.
Oh,
Pallor, yeah, right? They're super pale. Like, now here's a thing too. So, you know, different skins have different tones, right? And so in a person of Caucasian background, your skin is flush, right? And it's light so you can see the redness. But a person like myself of a darker tone, you won't see it the same, right? Because we're darker. So we have more like a ashen look, right? It's you're like, well, how do you tell? Because, you know, I don't see the pink, but you can tell. I remember there was this lady at my church and she was anemic. She was darker than me, but as soon as she walked in, she just looked ashen. Honestly, like in my head, have anybody been to a funeral before? Yeah. Have you seen like the pasty look that they have? Like that's what it looks like. It's like, it looks like they powdered her face with some white powder. You know, I'm like, is everything okay? And she was like, yeah, girl, I have anemic. It's chronic. I was in the hospital yesterday. I was like, oh, and I hadn't been a nurse then. So I was just like, something's wrong with this lady. What's happening, right? So yeah, we look different, but you can still tell. It's a different look. It looks more like ashen, like they put white powder on their faces, right? So yeah, you can definitely tell with pallor. Here, tell me one other thing that you can notice if a person is anemic. Shortness of breath. Yes, it's connected to that, right? So, good job. I heard it from two people. Yeah, so, you know, the body is like, okay, I don't have enough oxygen, so it's trying to catch its breath to, you know, you're trying to catch some breath in order to get oxygen back into your system. So definitely. So someone here, tell me another thing. If you're anemic, what you would be able to tell. How would you tell? Not those other ones, right? A new thing. Mucous membrane, yes, right? So usually mucous membrane is flush, it's red, right? Inside your mouth, right? You can see that, but this person, it's pale, right? Just the way the skin is, the mucous membrane, the conjunctiva, pale. You're like, it's like, where's the blood? Okay? Over here, what's another one?
Really dark under circles. I had a coworker that had like severe anemia, and she passed out in office, and her dark undercircles, and I guess what they had told her something about vitamin K.
Okay.
She had like a deficiency also because of that
Right.
vitamin K, and so that produces super dark under circles.
Right. So the only thing I would think there is, right, when you don't, like, if the blood doesn't get there, eventually it will darken because there's no life there. I haven't heard that as much though, so that's a new one to me. But the one connected to that, I would think, would be, what was I gonna say? Darn, it came to mind while you were saying it, because that's what I thought you were gonna say.
Yeah, they said it was something about the vitamin because she was very pasty, like
Right.
super white,
Okay.
and all that, but just like the
Under circle.
just the under circle
Okay.
was super.
Sure,
pronounced.
sure. So that's a new one to me, but that's a good one too. So another one would be, let's see. It could be jaundice. Which one would be the jaundice? Would be the production or the destruction? Destruction. And take note that some of them, it'll be super, like if it's like total lysis, then it's frank. Like you could definitely see it. There's no doubt about it. But if it's like not as bad, like you could still see a little bit of jaundice, but it's not as bad. So like, let's say if we have sickle cell anemia and the cells are being broken down, like you're gonna see jaundice there, right? And so you wanna be able to tell the differences, right? Which one is like super bad and which one is not, okay? Cool extremities is another one, right? Because blood gives you life, right? And so when I make the illustration of a person who's dead in the casket, why are they ashen? There's no life. There's no blood. And so they're cold, they're dead, right? So even a person who has life, who's alive, whatever, because the blood is not rushing through their veins properly to the to the extremities, right? They'll have cold fingers. And why is that? Where is the blood going instead, or making sure that it gets to instead, right? It's the heart, the brain, because those are the most important. So when your body feels like it doesn't have enough blood, it's gonna shunt it from your fingers, toes, it's gonna go to the heart and brain. And so that they're always gonna feel cold, right? When a person's in constant cold, we're like, are you anemic, right? It's the blood is not getting to the extremities, okay? So now let's talk a little bit about so here are some of the, we mentioned, right? Loss of the red blood cells, lack of nutrition, red blood cell destruction, bone marrow failure, right? And this is just an example of leukemia that we kind of talked about, right? Okay, so let's look at types of, here, part of the notes as well, interventions. What are some things that we're gonna do? So when you think of interventions, you have to think about the problem, right? What did I see and how can I fix what I saw? So this group, what did you say again? What did you see? Fatigue. So how do we intervene with that? What do we do? Okay, we can, how would we help their sleep cycle? Would we give them medicine to go to sleep? Not necessarily. How would we do that?
Encourage them to be more fatigued so they sleep better.
And I actually like that, but how would we do that? It's more like the cluster care, right? So it's like you want to pocket your interventions at some time here to give them time to rest, right? But you don't want to keep coming back. Remember we mentioned that last class, right? Clustered care will help with fatigue, right? But rest will also help with fatigue. Make sure they have adequate rest, right? Which one did you say in this group here? How would you notice? What did you say again? Pallor. So how would you fix pallor? So pallor happens because there's less blood. So what would we do to create more blood? Huh? We could, right? If it's super bad, like my friend I mentioned, and she was like ashen pallor. So she said, yesterday I was at the hospital, I got a blood transfusion, right? And so that might be something that you would do. But again, we said, to create more blood, so you can give it to them already made, but we can do something also to help the blood itself in the bone marrow, work better. So what could we do? Yes, we can give them epigen, right? The people who go to dialysis, they give them epigen to help create the blood. But let's say it's not that bad, right? What else could we do for a person who's, they don't need transfusion, they don't need erythropoietin? You and me, like, if we're like feeling weak, what do we do to help ourselves get more blood? Like,
Take a break and eat some broccoli.
yes, Eat, yeah, you gotta eat more iron, eat more green leafy vegetables. That'll help you, right? And definitely the rest for sure. But to help create more, you wanna eat better, right? You'll tell the person to eat better. What was yours? Shortness of breath. That's a good one. What will we do if we see someone with shortness of breath?
Avoid high activity levels.
Okay.
Range of motion.
Sure. So it depends on what's happening. But if I notice it right away, right? So the first thing I said, you say avoid, right? So then what we would do is stop the activity, right? We would stop whatever activity that's causing the shortness of breath, right? But now that, let's say they were not doing any activity, they were in bed and they had shortness of breath. What would we do then? Yes, we would do non-invasive, possibly first, right? Sit them up, right? Then what could we do? Let's say it's really bad. How would we know? Their shortness of breath. Is it anxiety? Is it asthma? Is it anemia? Like how would we know how bad it is or what it is?
They're gonna tell us on the same.
They could tell us. You're right. Pulse oximetry. We want to know. We want to know, like, how bad is it? Like, you're short of breath, but is it affecting your oxygenation? How low is your oxygen? Let's say we found that it was 90. What do we do then? We give oxygen, right? So when you think about the steps, okay, that's something that's important for you to know. What do I do first? I walk in and the person is short of breath. What would tell me I need to give oxygen first? What would tell me I need to intervene right away, like right now?
Well, I'm stronger and
The distress, right? If they're laboring, the stomach is moving, this costal muscles, you're like, oh my gosh, they're in danger. They're about to die right now. I need to give life, right? And so we want to give them oxygen right away, right? But if they're a little, I don't know what's going on. I'm just not myself, if it's restlessness, we want to identify that. So if it's visible that they're in distress and we see the shortness of breath, we want to intervene with oxygen. But if we're not sure, and we're I'm not sure, they look out of breath, we want to assess further, right? We want to put the oximetry on. We want to raise the head of the bed. Will that help, right? But if they tell us, we walk in and the patient is short of breath using a costal muscles, pulse oximetry is 98. Do we need to go assess again? No, they already gave us the assessment. We just need to give them oxygen, right? Okay. All right, what did you guys say? Mucous membrane. So how do we help with that one?
Well, depending on the cause of the anemia, you
Uh-huh.
could do B12 injections.
Okay.
Infusions.
Sure. So depending on what it is, we will regulate it that way. If, anemia, pernicious anemia, they need their shot. Maybe they haven't taken it. And that's another thing we'll learn a little bit about, right? And so this group, what did you say again?
These are the under eye surgery. but
Yes.
There's also she mentioned the nails.
Uh-huh.
the skin nails.
Ah, yes. That's what I was thinking about. I was thinking about cyanosis. So that darkness under the eyes can be dark blue, like a bluish dark color. It could have been that too. When you mentioned it, that's the thought that came to mind. But then as you kept talking, I forgot. But that could be that, right? So we have cyanosis, which is from the pallor to no oxygen, so it turns blue. And so then we need oxygen right away. And we need to find out what is the problem so that we can get their body perfused, right? Okay. Moving on. So these are the different anemias, which we kind of talked a little bit about, right? We talk about iron deficiency. They don't have iron. We're going to give it to them. So it's a lack of iron leads to decreased amount of hemoglobin. We need iron to make the hemoglobin, and we need the hemoglobin to capture the iron, which you'll learn in patho that the blood cell doesn't really like to capture oxygen as much as it likes to capture CO2. But the hemoglobin helps it, and each time it captures an oxygen, it makes it easier to capture another one and another one up to 4, right? So iron helps us with that. Pernicious anemia, we mentioned, lack of B vitamins, the B12, right? Aplastic is a decreased production of all cells produced by the bone marrow. And which one was this one that we covered? Decreased of all cells, what could be that?
Oh, NC something.
The leukemia, right? The production, there's a decreased production, right? So cancer therapy, because it's a cancer. And then we have the hemolytic. So red blood cells survive less than the normal 120 days. That's something to remember. So blood cells live in our body for 120 days, right? And that's important when we think back to diabetes. How does that remind of us something in diabetes? Do you remember? There's a lab that you take that connects to this 120 days or 3 months. HbA1c, that one. HbA1c. Yes, it tells us how well the person was observing their diet or their diabetic diet, and like you could be good for a day or two, but then are you good for 3 months? And the blood captures whatever nutrients it has, and it can calculate what it has been receiving for the 3 months. So it's important to know that 120 days. But hemolytic, so sickle cell is a problem there because they're all ill-shaped. They don't live as long, right? And then we have the anemia of chronic disease. So various conditions over the long term can cause decreased production, kidney disease, diabetes, tuberculosis, HIV, right? So these are all the different reasons, right? And what I want you to remember is all of them will cause a problem with blood. Whatever the problem, it's going to be some similar outcomes and some similar interventions. But once you know why it happened, then you're going to know how to solve it. Iron, you're going to give iron. Pernicious, you're going to give, if it's B12, you're going to give B12. Aplastic, well, they're not producing it properly. Oh, it's a cancer. I'm going to give chemo. A hemolytic, well, they're not living long, so I got to do something to help prolong their life. So like a sickle cell patient, I have to say, okay, well, what makes it clump? Oh, stress. So stay away from stress. Oh, you're not hydrated, so drink some more water, right? Oh, if you go too high up in altitude, it clumps more. So don't go to high altitudes. So understanding what causes it will help me do my interventions, right? And then the anemia of chronic disease, well, it's a kidney disease. How do I fix that? Keep the kidney healthy, right? Make sure you get hydration, make sure you eat the right things, or take your medication or do dialysis, all of these things, right? Okay, so now let's get to thrombocytopenia. Okay, so with thrombocytopenia, we have it's focused mostly on platelets. So we have a decreased production of platelets, and these are the numbers, right? And remember I mentioned like the most important is the worst case scenario. So always try to remember the worst case scenario and work yourself up, right? Well, definitely remember the norms, right? That's important. But the thing about that is they're gonna give you the measurements, okay? But you need to know what happened. So this of all of them is the worst case scenario. And it's worse because these people are not doing anything and they're bleeding, right? They don't have to bump into anything, floss or anything, shave or anything. They're just sitting there and boop, something bursts and they start bleeding, okay? So this is the problem there, okay? So platelets are produced in the bone marrow. We have megakaryocytes, large bone marrow cells that produce thrombocytes, right? So creation of platelets, liver releases the hormone TPO that causes platelets to mature. So remember we mentioned the epigen or erythropoietin is created in the kidney. Well, the platelets, they are, the hormone that releases them is from the liver, right? So TPO reaches the bone marrow, attaches to platelets, causing the release into the bloodstream, okay? And we have spontaneous bleeding. So when you think of, again, remember I said, you gotta remember the most extreme things. Those are the ones that I'm gonna put in the exam more so. I'm gonna put other things too, but I want you to be able to identify the things that's gonna kill somebody, because that's how you're gonna be safe, right? So spontaneous bleeding. So if it's a GI thing, right? If a person's just like, oh, I have like really bad stomach ache, and it's like, I don't know what happened. Like I was just laying in bed and like my stomach, because the stomach has so many organs and you don't know which organ is affected, you want to be very like alert about that, especially if you know the person is anemic of some sort and they have like spontaneous, because they could be bleeding in there, some GI bleeds, right? Also, we want to be careful if the person has some kind of, head issue, right? Because that's our brain. We don't want the brain to be affected. So if they have some like excruciating headache and you're like, I don't know, I just woke up with a headache, and you know that they have spontaneous bleeding, you're like, let's check this out, okay? So we want GI and respiratory too, right? Because the lungs is our life, right? So if the lungs go, the brain go. Okay, so we want to make sure spontaneous bleeding, if someone mentions their GI, if they mention their respiratory, and they mention their head, then we worry, okay? Because those are where our most important organs are. So it's a lack of production. We can have increased use or destruction. So if it's increased use, so it's more like if the person clots too easily, that's not good either, right? Which one is the one if they clot too easily? We talked about, remember the pregnant woman, the back of her leg. What was that one? Yes, deep vein thrombosis. Person flying, like I'm on the airplane and I sit my behind down somewhere. I never get up hardly if I don't have to use the bathroom. But every time I go to the bathroom, there's a whole list of people just standing around, walking up and down. I'm like, why are they doing that? Because someone told them you can't sit for a long period of time. My trip was like, when I went to Ghana, it was like almost, I felt like it was like 24 hours. But it was like 17 hours on that plane, right? I know some people are like, I can't even do that, and I don't even have deep vein thrombosis, right? But for people like that, they have to walk up and down. Even if they're driving, they gotta pull over because their body naturally builds more blood clots, okay? But it could also be destruction too, right? Where the blood clots die easily. The blood cells, they bleed easily. Right? So these are the people who, like with the, what we just mentioned? The spontaneous, where they don't clot well. There's one that I had mentioned last class where it was at birth and it happens mostly to males. Which one is that one again? Someone mentioned it here. Starts with the H. Like I remember I was doing a play in college and I was also making their costumes. Not that I know how to sew very well, but anyway, besides the point. So I'm about to fix this young man's jacket, and he's like, and I'm like, relax, calm down. He's like, no, I have blank and I bleed easily. Hemophiliacs, right? So they bleed so easily, and it's because of some kind of gene in their body that naturally causes them to bleed very easily, right? So they could be that too. So others, we have blood dilution, distribution problems, drug-induced with heparin-induced thrombocytopenia, HIT, and autoimmune diseases, right, with like the young man that I was mentioning. So when we look at HIT, so this is one of those extreme cases, right, that we want to look out for. So the thrombocytopenia is called HIT, or drug-induced thrombocytopenia, is known as heparin-induced thrombocytopenia. And this is when the heparin is the most common drug. When heparin is injected and it's an anticoagulant. Hold on, let me see. So the immune reaction may cause the medicine to produce blood clots and thrombocytopenia. So you give it to the person in order to help the blood not coagulate, but somehow the immune system says you need to coagulate because you're bleeding, right? So the heparin is making them stay uncoagulated, but the immune response is like, oh, there's not enough coagulation here, so we need to coagulate to fix this problem, right? So it's kind of like fighting with each other. Like what it's meant to do is doing the total opposite because the body is realizing, oh, you're doing your job too well, we need to fix it, right? So what will we see? Okay, so kind of like very similar to what we've been talking about, right? We say we're gonna see anemia, we're gonna see fatigue, we're gonna see pallor, we're gonna see weakness, right? We're gonna see blood loss, and here are the labs we're gonna look at. The one thing about hematocrit that I thought was very curious, when you think about the kidney, you're gonna notice that, right? So between the hematocrit and the BUN too. So when a person is dehydrated, their hematocrit level will not necessarily indicate what's happening, because it's usually like, okay, so you have red blood cells and you have fluid like plasma, whatever, and when you spin it around, the blood cells might be less than the plasma, but it's just in relations to how much fluid is in the body, right? So it's not necessarily that they have less blood, but it's that in comparison to the plasma, it's less. So just be mindful of that, okay? So then we have nutrition. So what are some of the things? Here are some things we didn't mention, right? So nail changes. We have the necrosis. So that one, and I actually had to look this up again. Where did I put it? So I thought I looked it up because I was like, what is that again? So this is when, I believe when your nail is the opposite direction. So usually we have like a spoon shape, like this, right? That shows like we call clubbing. Clubbing is a problem. When we get to oxygenation, we'll see more of it. So clubbing is when you have like thick spoon-shaped nails, and that tells us the person has had oxygenation issues for a while. But the colocytosis nails, I believe that's when it's the opposite shape. So it's like this, it's like a U shape, right? But I'll look that up one more time. Represents with spoon-shaped nails, known as, yes, there it is. Okay, I did write it down. And then we have the, what is this? The chelosis, and the chelosis is cracks in the corner of the mouth, right? That's what that one is. What else? We have the smooth, sore tongue. That one is mostly in pernicious anemia. And another thing to note, right? Different people use different words. If a person comes in and they say, my tongue hurts, what is that saying? They have a sore tongue, right? So it's the same thing. So if you're looking for Christian, it says sore tongue, and you're like, but it's supposed to say sore tongue. Where's sore tongue? If they say their tongue hurts, it's sore, okay? So just be mindful of, as you're reading these questions, they could use different words to mean different things, right? And it's also, they could say beefy red tongue, right? When you think of inflammation, does it hurt? It does hurt. So if it's beefy and it's red, it hurts, right? So they don't have to say, my tongue hurt. They could say, my tongue is like beefy and red, right? It's already, my tongue is inflamed. So all of this means it hurts, okay? All right. Then we have pica. Pica is another one that tells us that a person has anemia, right? So this one happens a lot in pregnant women, so you'll hear this again in OB, right? And this is for people. Oh, shucks, I forgot it. I was thinking about my 325 class. Anyway, I went to Ghana, right? Well, first, let's go back. When I was in Haiti, when I was little, right? I came to America when I was 5 years old. But when I was little and I came to America and I was in a classroom, like I was 5 years old, right? So I remember the teacher was writing on the board and she had a green chalk, can't say it. Anyway, and I looked at the chalk and I was like, oh. So then, and you're gonna see why I did this. So I go to the chalk and I bit it to taste it. And I was like, this has no taste. And the reason I did that was in Haiti, my mom had pica when she was pregnant with my brothers. And what that is women eat non-food substances. And there's this greenish looking clay that they eat, that they put some salt in it or whatever. And I always saw my mom, she never gave me any, mind you, right? But she always would eat it, and that meant that she was anemic. Like, I don't know if she didn't know that, but I remember seeing that. So when I came to America and I saw the green chalk, I was like, and I ate it. So anyway, I went to Ghana over the break and I saw the clay and I was like, oh my gosh, I have to bring it so I could show the class. So I'm gonna try to remember to bring it so you can see it, right? And I was thinking about OB, and I teach 325, which is the NCLEX review thing. So I'm like, oh, I gotta show them. This is what I was trying to eat when I was 5. But this is something that tells doctors, if the person tells them, I'm chewing ice, I'm eating clay, or something that's not food but that somehow fulfills that craving. They're anemic and they need to increase their iron, right? But I thought it was so interesting when I was like, I want to buy that, and my friend was like, huh? Because he knows usually it's people who are pregnant. He's like, huh? It's like, no, that's not why. Anyway, and then we have the hemolytic, which is the jaundice, right? Where we're gonna see the person like they look yellow, right? So they have yellow eyes. So anywhere that's it goes through their skin. Again, another quick story. I remember after learning about this when I was in nursing school, like I'm looking for everybody with anything that I noticed in school when I go back to New York, right? So I'm on the train and like I'm looking at, who has club fingers, right? And then I'm like looking at people's fingers, and then I'm like, nobody here has club fingers? And I remember it was like Labor Day. We have like a quick little holiday for Labor Day. And this one girl, she was Haitian, and I remember because she had a do-rag that had the Haitian flag. And then I looked up, I was like, oh, nobody has. And then I looked up and her eyes were yellow. I was like, oh, she got jaundice. And I was like, and I had to go to her to tell her, do you know your eyes are yellow? Do you know? You have jaundice. And then she was like, yeah, I know. I have sickle cell. I was like, you don't.
You got excited.
I got so excited. She's like, yeah, I've had it all my life. Like, okay. Then she walked away. But this is the life of a nursing student. Like, you're like trying to diagnose and help everybody. Like, I know your problem. I could save you. So, you know, yeah, that jaundice is real. Like, you can see it. Obviously, you know, a person with liver issues, you'll definitely see it in them, right? Like actually, you know, liver disease, but people with blood issues will have it as well, okay? So how are we treating it? We talked about this already, right? We're going to correct the underlying problem. What the problem is, we find out, and then we're like, okay, this is the solution for this exact problem. If it's B12 problems, we're gonna give them B12. So the thing about B12 with pernicious anemia patients, right? Once they find out that that's the problem, usually, if they're going to do the surgery and they know they're taking out that part of their stomach and they're going to remove their intrinsic factor, they have to give them the B12 shot. And I think it's so when it first happens, they give them the B12 shot every week for a certain amount of time, I think for a month. And then after the month, they take it every month after that. And they will take it for the rest of their life because they cannot take B12, right? The other thing too I had to mention with B12 as well is it can be found in animals, right? And so people who are vegetarians, they don't get it from animals. But where could they get it from? Vitamins or vegetables, right? They can get it from vegetables. So then we have the phosphorus sulfate, right? Which is the iron. So you're going to give them that too. So what do we tell them if they're taking the phosphorus? What is something that we know is a side effect?
Black stools.
Black stools, right? What's the name they call it? There's like a scientific name that I always forget. Melena, right? It's called melena as well. It's dark stools. So we tell them, don't worry, if you see that, it's going to be okay. But there's other things we'll tell them too, like if they have to do the liquid, because it's, yes, use a straw because it'll stain your teeth, right? You want your pretty teeth to be white, right? What else would we tell them? Oh, another thing too, is it this one? That if they're taking it in an IV, that it has to be diluted because it's strong, right? So you want to dilute it. I think more than a certain amount, more than 10, then they have to dilute it because it's caustic to the veins, right? So that's another thing that we nurses, we should know. And then we have the folic acid. So folic acid, helps with the creation of certain proteins. And you're going to see this again with pregnant women. Because if a pregnant woman doesn't take her prenatal vitamins, which includes folic acid, their baby might develop spina bifida, which is a tubal defect, right? The spinal cord won't form properly and it'll be opened up, right? So that's something else that we need to know. And then we have the erythropoietin, which does what again? What does the erythropoietin do again? It makes blood, right? So depending on what it is, we're going to give that. If we need them to make more blood, we will give. And with the thrombocytopenia, right, we're going to correct, again, underlying cause. If platelet transformation, we might give them platelets, right? Decrease offending drugs. So if it's the heparin, we're going to stop the heparin, right? Prevent bleeding risks, right? And we had mentioned that. How did we do that again? No flossing, no contact, soft brush, no shaving with the razors, right? Okay, more on intervention. Provide rest periods, we mentioned that already. Educate. What is the education part going to do for them?
The more they know, the less likely they are to make it worse.
Yes, less likely they are to make it worse, and less likely they're going to return to the hospital with the same problem, right? Because that's our goal. Educate them so that this doesn't happen again. So definitely. And we administer the medication, whatever it's going to be, whether it's iron, whether it's B12, whether it's the Epigen, right? And with the thrombocytopenia, minimize the person's risk with injuries, no contact sports, prevent falls. How do we prevent falls?
Make sure that they have, like, if they need mobile assistance.
Yes, I love that. Mobile assistant, walker, cane, teach them how to use it. How else? Bed alarm, yes, make sure the bed alarm. How about the floor? No rugs. And what else? No cords. So make sure the cluster. And then also put things close to them, right? So that they're not reaching out or trying to go get something that they need. Glasses, glass of water, bring their tray table close. And then we want to reduce bleeding risk. We mentioned that already. Prevent infection. We talked about preventing infection. How do we prevent infection?
Washing our hands.
Washing our hands. That's the biggest one. What's another one? Say it again.
Avoid crowds.
Avoid crowds, right? We talk about, like, if they're coming out, they wear a mask. If you're going in, you wear a mask, depending on, like, let's say if they're immunocompromised, right? That kind of thing. And we monitor INO, right? Why are we monitoring INO?
You're looking at the color of the bleeding.
The INO, input and output. So when we think about the quantity of blood, it has to do with the fluid, right? So if they're drinking enough water, then we know they might have enough. Remember I mentioned, like, the level of the blood to the plasma, it might be less, and that might tell the body, oh, you don't have it. When a person is dehydrated, that the body can feel like, oh, you need more of one thing or the other. So we want to make sure. And clotting too. The less blood we have, the less blood, and it's not flowing properly because it's not fluid enough, it gets thicker, right? And so then it could clump easily. That's what happens with sickle cell anemia. We want them hydrated. When a sickle cell patient comes in with crisis, one of the first things we do, IV insertion, push fluids, right? And then we give them pain medication because they're in a lot of pain. They're always in pain, poor things. Ugh. Okay, how do we diagnose it? Anemia, CBC, vitamins and iron levels, we want to check. Thrombocytopenia, CBC, okay? All right, let's answer some questions. Let's see if you know this. So a patient diagnosed with aplastic anemia has a neutrophil count of 1,200. Based upon this finding, the nurse would include monitoring for which potential complication as part of this patient's plan of care. So look at the answers really quickly. And I can go back really fast to this. Remember those numbers? And let's go back. I know it's fast, but you might not need that. But let's go. Because, you know, you're going to have the levels. Next time I'll add them in there. Anyone think?
Those are platelets and it says neutrophils.
Oh, did I say? What did I do? Oh, you're right. I didn't have, you're right. I apologize. So it is the neutrophils. You're right. I apologize. So the answer is 2, severe fatigue. So the neutrophils having to do with the person is going to, so the adult level of neutrophils are about 1,500 to 800 or 1.5 to 8 neutrophils per microliter. So high levels of neutrophils are more than 800 neutrophils, okay? Stem cells in the bone marrow produces blood cells, red blood cells, white blood cells, and platelets. In aplastic anemia, stem cells are damaged. As a result, the bone marrow is either empty or contains few blood cells. So the most common cause of aplastic anemia is from your immune system attacking the stem cell in your bone marrow. Thank you. So, severe fatigue. Here's another question. The patient on heparin therapy has developed an arterial occlusion in the right leg. The medical team suspects heparin-induced thrombocytopenia and discontinues the heparin therapy. The nurse should teach the patient that the treatment for thrombocytopenia problems will likely end at which time. So this is a knowledge question, and it's 3. So within a week of time, the heparin has to be discontinued. This is something that's directly pertaining to the heparin-induced thrombocytopenia. So it's a growing complication of a common medication used to prevent deep vein thrombosis. Once a drop in platelet count is observed in a patient, it is important to rule out HIT. When HIT is first suspected, it is important to discontinue all heparin products. Okay? Okay, so with the time that we have left, just read this case study amongst you. Pull out your laptop so you can see the case study, and we'll see how many questions we can answer together. So just go ahead and read the case study, and then we'll possibly just do it together. So a 72-year-old male whose wife died 6 months ago is brought to the healthcare provider by his daughter because he's not eating much and has been lethargic and sleeping a lot. He has a history of hyperlipidemia for which he takes niacin, levastatin, Advocor, 500 over 20 milligram PO daily at bedtime. So here are some subjective data. Has been unusually tired for the past couple of months, is frequently short of breath and sometimes feels like his heart is pounding, has lost weight because his wife always used to cook for him and he doesn't cook for himself. Describes a typical daily meal as coffee and a donut for breakfast, a hot dog and lemonade for lunch, and a jelly sandwich on white bread and coffee for supper. And objective data on the physical examination, they found his blood pressure was 118 over 72, pulse 98, temperature 98.2, respiration 16, oxygen saturation 92, on room air, height 5'6", weight 135, BMI 21.7, S1 and S2 auscultated and regular, bilateral radial pulses, 3 and regular, lungs clear bilaterally. Okay, so here are the labs and we'll come back to them. Next time I'll put the norms right next to them. Okay, so here are the questions. The first question, interpret DC's laboratory results. So, when we look at this, we know the red blood cell count should be 4.2 to 5, wait, no, he's a man, so 5.7 to 6.1 million, and that's what it is there. Hemoglobin normally for men is 13.2 to 16.6, so that's a problem there. Hematocrit should be, for men, 38.3 to 48.6, right? So just looking at this, you know, what are some of the problems that you think? So anemic, malnutrition, okay. Let's see, what is his platelets? Platelets should be 150 to 450, and his is 250, so it's not too bad there. So he's not anemic. I mean, he's not bleeding, sorry. His iron, the iron should be 10.74 to 30. So his iron is 28, so that's fine, right? Okay, so let's move on really quickly. So we could, once we know the norms, we can see what the problem is. So now, based on the laboratory data and assessment findings, the healthcare provider diagnosed DG with iron deficiency anemia. Which clinical manifestation of iron deficiency anemia does DG have? So if he has iron deficiency anemia, what are some of the problems that you would suspect?
The breathing problems.
He could have breathing, he could, yeah, and that's where we see that, right? So we have the breath, what's his breathless? So his respiration is 16, so he doesn't have, it's not that issue. So what's another thing? What other things could we have with iron deficiency problem? Fatigue, right? So he did mention that, what did he say? He's lethargic, right? So we can see that, yep, that is in alliance with that, in connection with that. What's another thing he could have? Oh, let's go back here. You can kind of pull it out from here. So that, I think like the lethargic is the biggest one. Right? And then we see that because look at the food he's eating, right? Where would he get iron from?
The hot dog.
The hot dog? If it had what's that vegetable thing you put on it? Relish. Maybe. I don't know. Okay, another question. Explain iron deficiency anemia and identify the probable causes of his anemia. So we already mentioned that his diet and the iron, he doesn't have what? What doesn't he have in his diet that's causing him to have anemia?
Iron.
What has iron in it?
Green.
Greens. Yes, he doesn't have any greens in there. Oh, sorry. Then we have, how is iron deficiency anemia treated? What would we do for him?
Give him green.
Good. Yes, we would teach him to change his diet, right? So we would provide greens, but how fast would that work if we just give him lettuce and kale? It would take a while. So what we might have to do? Supplements. Supplements will work faster because they won't need to break down as quickly. If it was severe, then we would have to do what?
Give him blood.
Not blood, but we might have to give him iron IV. But if we need to, then we can give him blood. And remember I mentioned when you give blood, there's iron in it, and if you give too much blood transfusion, there might be too much iron accumulation, so there is iron in that. Okay, identify dietary iron sources. We already mentioned, but give me some. Green leafy vegetables like what? Spinach, kale, yeah, or we can just give him a pill. List at least 4 important points to include when teaching him about iron supplements. Give me them. Drink with if it's liquid. Yes. Dark stool, yes. Drink lots of water, right? And what's something else too? Constipation. How old is he? He's already older. So his intestines are slowing down. So he's definitely going to feel that. That's why he needs to drink lots of water. And then I think there's another thing about milk, not drinking it with milk.
Oh yeah,
Right? It stops the absorption, right? So we got to tell them that. And we're done. Oh, wait. Have a great day, guys. I will be posting this because it worked. Yes.
For people that have us today, are we going to get our
So yes, I had sent all those. Oh yeah, really quick, guys. Your ID badges. I'm sorry for the bombarding of like constantly reminding, but I found out on Friday I actually had to go there because I wasn't hearing anything, and so they told me what I needed. Everyone for Monday should be okay. So I don't have anything physically with me. So when you go there, I'm gonna be there. That's what it is. Yes, I will be there, and I will go pick them up and hand them to you when we get there. Okay. And so those of you for Tuesday, if you haven't sent me your stuff yet, then definitely just send it to me and, we'll just play it by ear. But sorry about that.
Professor, can I talk to you about that for a second?
Sure, come on down.